Welcome to Pause for the Truth, where you can sit back, relax, and hear an honest dialogue about health, wealth, legal, and social issues. The hosts are Dr. Rogers Kane, family practice physician, and Jocelyn Turner, health education consultant, with co hosts from the Northeast Florida Medical Society and its foundation. Stay tuned for the truth about matters affecting you and your family. We're here to tell you what's really going on and why.
Hi, my name is Teresa Osgood. I have two chronic venous ulcers and I see Dr. Wells for wound treatment. I went to the emergency room about my knees because my knees were bothering me, and the young lady saw the wounds on my ankles, and she was the one that had got me in contact with Dr. Wells, and I've been seeing her ever since. I just love her. I love everything about her. I love her spirit. She had every opportunity to give up on me. It used to be so painful to where I couldn't even allow her to touch my wounds. And I don't know, she just kept on me, and she kept praying, and until one day the pain was not like it used to be. She's amazing. She's amazing.
Good evening.
Good evening, and welcome to Pause for the Truth. I am your co host, Jocelyn Turner. And sorry, I forgot to turn on my camera, so that would not have been good. Last week, if you follow us, my camera was too dark. So I tell you what, I don't know, Dr. Kane, it's a jinx on me. What's going on? How are you doing this evening?
I'm doing fine. I am happy to bring one of my esteemed colleagues to the show that does such great work, but we'll get into that. But I'm doing fine, probably better than the weather, unless you like rain.
Well, coming from behind the scenes, before we introduced our guest, is our behind the scenes, allegedly behind the scenes technology wizard, Tyrone Jackson. How are you doing this evening, Tyrone?
I am doing well. Well, thank you very much. I'm just on the screen to keep the symmetry right.
Oh, is that what it is?
But
Well,
he didn't say the beautification of the symmetry.
the symmetry, right. I got you. So, well, tonight's subject is, in my opinion, very intense, Dr. Wells, but I know it's going to be a good one because Dr. Kane has talked about you for eons. So we're super excited to have with us Dr. Carol Bowen Wells. How are you doing this evening, Dr. Wells?
I'm fine. Thank you. Thank you, Dr. Kane. Thank you, Ms. Jocelyn, and nice to see you, Tyrone.
All right.
So, for those of you who don't know Dr. Bowen Wells, she is a board certified wound care physician. That's right, wound care physician and general surgeon. Now, if any of you have ever known anybody to have a wound that didn't heal on its own without seeing a physician, then this conversation tonight is going to be very close to hit very close to home for you. I can recall, Dr. Wells, when my great grandmother had, it was a joke where not a joke, but she used to tell my great grandfather, Wilson, stop stepping on my foot. And he stepped on her foot so much. I'm a youngster, so I didn't know any better. But after a while, I noticed her foot was amputated, her leg was amputated, then the other foot and the other leg. No one ever explained why, but I just saw my great grandmother's health deteriorate once those limbs start being amputated. So, what are the signs that a wound is not healing properly and needs professional attention?
Well, I think, again, I just, want to thank God and thank you guys for the opportunity to speak about a subject that is so important. Anytime you have a wound that is not, when you get injured, your body creates platelets that should plug that bleeding site. And they should go through quickly an inflammatory stage and then a proliferative stage and then a maturation phase. And by 28 days, that should be completely closed or what's called epithelialized. It does take a while for the maturation, which is that scar you see that form. However, what happens a lot of times is that the wounds get stuck in the inflammatory stage.
Mm.
And after 28 days, it's considered a chronic wound. And that is when you really need to see someone who specializes in wound care. Particularly, you talk about diabetic foot ulcer. That is actually something that really needs to be spoken about a lot more, because diabetic foot ulcer is an independent risk factor for poor outcome. It's an independent risk factor for an amputation up to 20%. And the mortality rate is almost 50 to 70% in 5 years. Now, if
Mm.
you just think about that, you're diabetic, and over 11 million Americans have diabetes. And Dr. Kane could probably speak to these numbers more specifically. But what happens is that the diabetic incidence increases, which means that if you get a diabetic foot ulcer or any wounds on your foot, for that matter, it may take much longer for your wound to close. Now, let's just go through it pretty briefly. So you have a wound on your foot, you ignore it. By the time you get to see a doctor, it might be what for most people considered too late. But you should never just take somebody's word that it's too late and cut it off. Because
Mhm.
what happens is that persons, as you explained about your grandmother, first they lose their toe, then they lose their foot. Their 5 year survival has gone from 40% to 50% are dead in 5 years, and it can go all the way up to 80% are dead in 5 to 10 years, higher the amputation. So what we need to do is we need to get a quick jump on these people. We need to treat their diabetic foot ulcer. We need to treat the infections. We need to treat the disease itself, and then the wound that's in the patient who's a diabetic. Now, let me just give you some of the quick statistics since I mentioned mortality rate. Um, if you look at breast cancer, 98% of those people are going to be alive in 5 years. If you look at a person who was at an above the knee amputation, maybe 20 to 30 are alive, percentage are alive in 5 years. So the mortality rate increases significantly just by having an amputation. Not only that, your
Wow.
lifestyle changes. You might not have the freedom to go and do what you want to do. Next thing you know, you end up in a facility where someone else is taking care of you, because walking with a prosthesis requires a lot of energy. It's a lot of work on you, a lot of work on your heart. So if you're not young and healthy, then that becomes a really horrible setback for those patients.
Yeah, I was looking
What?
at the video. I'm sorry, Dr. Kane,
No,
looking
go
at
ahead.
the
Go ahead.
video of the young lady who she went to the doctor for another reason. Her knees were bothering her, but fortunately, the medical person noticed her ankle and the sore. Why is it that people, could she, I mean, and I'm not judging her, I'm just asking,
Right,
how do
right.
people miss that though?
Well, it is, because a lot of times, as she said, she's going in for one thing. And a lot of times, unfortunately, you go in for one thing and people just focus on that one thing. But if you don't take the time to look at the other things, a lot of things get missed, and wounds are not considered, the most important, I guess, at that time. So she did have a good nurse that recognized she had a very large wound that needed to be treated. And that's kind of how she came. And, that patient, can have not just a diabetic foot ulcer, but you can have venous leg ulcers, which also has an impact if it's ignored on survival. Of course, their 5 year survival is not as bad as a diabetic unless they too are diabetics. And then it does have an impact. But the disease process itself is completely different for venous versus diabetic. And then the other interesting thing about a diabetic foot ulcer, if it's ignored, it could lead to an amputation and early death. But even if it closes, there's a 65% chances that it could recur in 3 to 5 years. So these patients continually need to be followed to, if there's any hint of a recurrence, that they jumped on pretty quickly.
One of the things that I can say, because I'm the person that usually send them to Dr. Wells, because I'm looking at it going, I don't know what to do with that. And what we see is a lot of patients either don't tell the doctor, or they're treating it with Neosporin and think it's next to nothing. They don't see the severity of it early on. Sometimes they may have, you can have a foot ulcer that can go pretty deep, and a person thinks it's pretty superficial. And then they may even go to other physicians whom feel that they could probably treat these ulcers themselves. And before you know it, it is such a mess. I do that, what I call either the Jacksonian March, which is where they start with a toe, then they go up with a half a foot, then they go up with a foot, then they go up with a below the knee amputation. All it is just a steady march, steady drumbeat of cutting these people limbs off. And some of the, and I hate to say it, bad as much as it happened, I really do hate to say it. Some of the clinicians just tend to ignore, don't take as seriously as myself, and be honest with you, Dr. Wells, don't take as seriously what these wounds, what the outcome of these wounds could mean, especially in certain socioeconomic group of patients, without saying anything worse than that. So,
yeah, that's why we talk about those social determinants of health, and we talk about health equity, and just because we want to make sure, and I say it all the time, all of us want the same thing for ourselves and our family, right? So you want access to care in, close to proximity where you are. Dr. Kane talks about it all the time, that as his aging, or geriatric, that's what he says, his geriatric population of clients, as they don't want to drive far anymore, when they have to go and see someone that's so far away, if they don't have a family member to take them. So it's just real interesting. I know, again, when you talk, Dr. Wells, about the life expectancy after the wound gets so bad. You know what? I think you're right. I think my grandmother did die within 5 to 7 years after the amputation started. It so young, I didn't know what it was. And I just know, obviously, as I got older and went to school, the one tip that and I'm a health educator, Dr. Wells, one tip that I learned years ago in doing diabetes education is to tell our patients at the time, if you're not flexible enough to sit down and bend your knee enough to see the bottom of your foot, get a mirror and take a hand mirror, and look up under your feet in order to, and I find myself doing that, even not that because I'm not flexible, but because I'm not flexible. Because when I got my knee replaced, I didn't pay attention. I didn't do my therapy right. So the range of motion is not the best. So for whatever reason, it's just a good idea to pay attention to. I was telling Dr. Kane yesterday, remember that advice you gave me about something it was? I didn't pay attention then, but I did now, right? And you see the benefits. So how can patients and caregivers better prevent wound infections at home?
Well, let's go back to, what a wound is. A wound is a break in the skin. And as I say, it should close within 28 days. And after that, it becomes a chronic wound. If you have a wound, it should be getting smaller with time. Some of the wounds that I see are really large. So yes, it takes a much longer time to see a decrease as you would expect for a smaller wound like it's on the foot. But the pain, if you're diabetic, you might have neuropathy, which is another situation. But the pain should decrease. The fever should go away. The inflammation should decrease. So there's a number of different things that you should physically see with your eyes when you're seeing the physician or the clinician taking care of that wound, that you should see improvement. The depth of the wound should decrease. The square centimeter should decrease. So there are things that you're looking at every week that, the base of the wound should become granulation tissue, which is that proliferative stage I mentioned before. So you should see physical signs that the wound is improving with time.
Dr. Wells, that first patient she showed happened to be a patient of mine. So she agreed to come on the camera. And I had nothing to do with that promo. That was Dr. Wells and that patient. That lady, they were threatening to amputate her limb, a piece of her limb. And when she came to me and she told me what was going on, I was like, oh, hell no, you're not going to get that cut off. Let's send you to Dr. Wells. And you heard the young lady testimony herself. Saved her limb, and she didn't get into as much details as I can, but it actually saved her limb. And then by default, it saved her life, even though it might have been a little later down the road in terms of that. But we also have to stay in touch with those people, because as Dr. Wells said, there's a recurrency rate that if people don't change, which both of you guys know it's difficult.
Mm-hmm.
If you don't get them to change their lifestyle, there's a good chance that this wound may recur again. So that's when it comes back and fall back on me, that now I got to make a difference with the rest of the stuff that's going on. Since Dr. Wells is saving that limb, it's up to me at that point to help save that life beyond what Dr. Wells is doing.
So are those wounds typically associated with diabetes, or can you get a wound from a variety of causes?
You can get a wound from a variety of causes. You can get a wound from a pressure injury, where particularly if a paralyzed patient who doesn't get turned, that persistent pressure in that one location will compromise the circulation, then the skin will turn black, and then the skin will die. And there's different stages of that. You can get wound from having surgery, and that surgical site got infected, and it retarded or slowed down the wound healing, and now you have a wound that you have to deal with. You can have wounds from a disease process called hidradenitis suppurativa, which is common in African Americans, where you can get boils under the armpits, boils between the crack of your bottom, boil between your groin, and they are painful. They fester, then they rupture, they fester, they rupture, and then they become chronic disease sites for years, 10, 20, 30 years. And actually, if you pay attention to the television now, you're seeing ads on the TV that talks about hidradenitis suppurativa. And I have been taking care of a lot of patients with that disease process, where these are usually younger people, and it becomes a very disabling disease process for them. They're not able to go out with their friends. They're not able to wear certain clothing because they always have to have dressings. It's draining, it's pussy, it's smelly. And usually they have failed the medical management, the Humira, the concentric, whatever it might be. And they come to see us, and we have to do the wide local excision. Some of these patients have had to undergo what's called a diverting colostomy, where we have to cut the bowel to bring part up, to drain the stool, to protect the lower part so that those wounds can close. I've had to do skin graft. And once everything is closed, you really change the lives of those patients. The other group of patients you can see is something called calciphylaxis, which it's usually seen in patients with end-stage renal disease undergoing dialysis, where it gets calcification in the blood vessels that lead to the skin, and the skin died. You can get wounds from, just basic trauma, where you run into something and you're on a blood thinner. Next thing you know, you have a huge blood clot sitting on your leg and it needs to be drained. So there's multiple different types of wounds, and each wound has its own ways of treatment, not just the basic, what am I going to put on the wound? But for example, if you have a pressure injury, do they have their appropriate mattress for offloading? Are they getting turned? Are they sitting on the appropriate surface when they're going places? If you have a venous leg ulcer, because your veins no longer work like they should, are you getting compression? is the venous disease have gotten so bad and your leg swelling have gotten so bad. So now you have secondary lymphedema. Is that lymphedema being treated? Because if you don't treat all the chronic medical conditions, then the wounds are not going to close. And then if they close, they're going to reopen. So the way I look at wound care is that it has to be comprehensive and it has to be multidisciplinary. I am a general surgeon by training. I'm actually a cancer surgeon by training and then started doing wound care. So I believe in using that whole approach of taking care of the entire patient. I mean, their patients come in to see me for one thing, and I'm saying, look, you need to treat A, B, and C because you need to treat A, B, and C to allow this wound, which is D, to close and remain closed. And after they're closed, then we continue with a surveillance program where we don't just, you're closed and you're done. We see you, we keep seeing you. So we always keeping an eye on what's going on with you at that time.
Yeah, I was just about to ask you, how do you educate your patients on wound prevention and management?
Oh, I do that on weekly. Every time they come in, I am all over them, and they will tell you that because they understand it's a partnership. You have to do your part. You have to eat well. Nutrition is very, very important in wound care. If you are not eating properly, if your nutrition labs are out of whack, if your vitamins are not within normal limits, you will decrease the healing time of that wound. If you have a venous leg ulcer and you're on your legs all day long, if you're not elevating your limb, then that limb is not going to go down. If I put a compression wrap on your leg and you go home and take it off, then you're not helping yourself. If you're diabetic and you're not sticking with that diabetic diet that you know you should be following, like I've had one person, I mean, they told me they're diabetic. They didn't know what I do at the time, and they have high blood pressure, and they stood there and they ate 2 bags of chips and something else that I know they should not be eating. And I'm like, I thought you were a diabetic with high blood pressure. So if you don't change the way you eat, you're not helping yourself. If your weight is not within a manageable number, you're not helping yourself. So I educate them on the disease process themselves, and then I talk to them about comprehensive wound care and management.
She also talked
Do the same for their family.
She also talked to their physician, me being one, to tell me she rats them out quickly. She will call and she will pick up the phone and call me in a heartbeat. You know, Miss So and so is doing this. I mean, she rats them right out. And the patient's in front of her, so it's not a secretive rat. She, you know, and she, as you can tell her, Carol has this personality like a surgeon that goes directly to the problem and say, "This is your problem. There's no need of masking it. There's no need of pretending. You're not doing what needs to be done to take better care of yourself." And I'm calling Dr. Kane. Now, that's what she do for me. So she'll call me while the patient's in the office. She can't reach me. She'll tell me what's going on. And what I have a very, very admirable stance with her is that she really cares about those patients. When she calls, there's something going on. And she'll sometimes text me, "Let me talk to you about one of your patients." And like I said, that's when she rat them out. But hidradenitis suppurativa can occur. One of the things I see most of the young folks is up under the arm. That's when they get these big knots and they can get pus in them and they can be pretty nasty. And particularly when it comes down to young women, I mostly see it in young women. I don't see it in men as much, but I particularly see it in young women. And of course, that affects their whole social life because
what causes it? What causes it?
It's a disease process of the sweat glands.
Oh.
And it usually starts in there, as I said, it's usually from the 20s, the 30s, and then you can see a second peak in the 50s. Yes. And it is really.
One of my youngest had it. But go ahead, Carol. I'm sorry.
So it is a really disabling disease, and you don't realize how crippling it is until you meet these patients and their lives change, and then they tell you what they've been going through. I mean, I had one physician who called me and said, I've had this patient, it's been 30 years they've had hidradenitis, and we have done major surgery on her armpits, groins, back, and with skin grafting, I did the colostomy, like I mentioned, and she's had no recurrence. It's been several years. But the way I look at wound care, the way I look at people in general, if you treat patients or people like you would want someone treat your family, then that's the best you can do for anyone. So just like I pick up the phone and right in front of the patient's faces, I will call their primary care doctor and tell them what they're not doing or even what they are doing. But if they need to see the infectious disease doctor, I would call them too. If they're going to go to lymphedema and they can't get in, I'm picking up the phone and call. Because the sooner they can start their comprehensive and multidisciplinary approach to their healing, the sooner that wound is going to close. And you can see the change in that patient when they see the progress of that, their whole demeanor changes. So when they come in, we no longer have to, tell them the whole spiel again. We can focus on what else is going on. How can we help you in your overall life? We motivate them.
It
Let me tell you what
seems though
lymphedema
that
is. I want to explain lymphedema real quick. If you see some patients, you probably seen patients with really bad varicose veins, right? And a lot of times you don't see that fluid returning from the legs, going back to to the heart and being gotten rid of by the kidneys or whatever. And so a lot of times you get fluid buildup in those lower extremities, and those varicose veins start bulging. Sometimes it's such poor circulation as a result of that fluid buildup that it can also cause constrictions around the area of that whole limb, if not both. Sometimes it can be one-sided, sometimes it can be both. And if it causes that fluid flow back to the heart to where it can be eliminated by way of the kidneys, if you don't get rid of that, they will limit the blood flow there. If you limit the blood flow, then you are limiting the healing capability within that limb. The next thing you know, they get an ulcer on the surface, or they may get some bubbles and fluids and stuff. Before you know it, there is a sore that shows up, and they tend to ignore it because it may be on the heel because they got bad shoes, because they got such fat feet from all this fluid accumulation, or it's just spontaneous development of it in the lower leg, especially near the ankles and stuff, and it's not from a friction of some rubbing up against it, even though that can cause it, as well as anything else. You tend to see a whole lot of those. You start seeing a lot of wounds developing in people whom are not allowing that edema to go away. Edema meaning buildup of the fluid in the lower extremity. And that's when they start getting in trouble.
Yeah, here's my thing though, Dr. Kane and Dr. Wells. To me, and then we're going to pause for the history maker moment, but I just wanted to put this thought out there, and then we can get back to it after the history maker moment. Oftentimes, in my opinion, as a health educator, people don't always know when it's time, when something, I hear people will say, my legs are big, just like my grandma's. Right? They think that that's just a genetic thing. They don't associate it with a cause to action that is something that needs a medical attention. And so we always tell people that's why you need a primary care physician. That's why you need to make sure you're going in to see a doctor for those annual visits, because we don't expect that everyone will know everything that there is to know about the different ailments that you all mentioned tonight. So that's the whole importance of going in for those annual exams, so that your primary care physician can look at you and say, hey, how long have you had that such and such on you? Like that nurse did. you know what I mean, in terms of seeing something. So I do want us to come back to that after the history maker, because I want our audience who may have a history of family members who had diabetes or other ailments, the knot under the arm and all of that. Again, people don't know that those are causes to get taken care of. So hit it, technology wizard, with our history maker moment and the video from Dr. Wells.
I'm sure you've heard the news. Wound care has come a long way in the last 50 years, but just how far? Let's find out. In the past 5 decades, we've gained a sophisticated understanding of wound healing thanks to groundbreaking research. New technologies and therapies have revolutionized treatment options, especially for chronic and complex wounds. Prevention has become a priority with a strong focus on avoiding pressure ulcers and diabetic foot ulcers. And let's not forget the multidisciplinary approach, bringing together various healthcare professionals to provide the best care possible. African American pioneers, though often overlooked, have been instrumental in these advancements. If you're looking for experts in these new breakthrough treatments, consider Dr. Angela Williams, Dr. Marcus Brown, and Dr. Lisa Johnson. Dr. Angela Williams specializes in diabetic wound care. Dr. Marcus Brown is an expert in pressure ulcer prevention. And Dr. Lisa Johnson focuses on bioengineered skin substitutes. Some of the most exciting advancements include advanced wound dressings, negative pressure wound therapy, and bioengineered skin substitutes. Growth factors and stem cell therapy are also paving the way for more effective treatments. Additionally, 3D printing technology and nanotechnology are opening new frontiers in wound care. Here's to another 50 years of breakthroughs.
Wow, that's all I can say. I
came in after having a problem with my lower legs. I was a patient of another wound care specialist, and I reached the point where she told me that she couldn't do anything else for me. Dr. Bowen Wells, she's an excellent doctor. She was the type of doctor that I really needed at that point. She was firm, but she was encouraging, and she got me through that very difficult time.
Well, I'm getting a little emotional, but these are tears of joy. My husband is an ex-naval officer, so he can be a tough cookie, but definitely he met his match. He had the perfect doctor and staff to help him. And I'm so grateful and so honored that the other doctor gave up and we were able to get the help that we needed. My husband has his feet back. He's not in pain. He's been back to work 3 weeks. He's been driving. And our life is the better, not just medically, but professionally and spiritually, because we met Dr. Bowen Wells.
Wow, that's a powerful testimony when you think about the impact. You know, we're about to have a men's health event in the end of this month. And the reason that we do that is because men don't always pay attention to their bodies as women do, right? And so for the couple to recognize that this is not the best person for my treatment plan, and moved somewhere else. So, you know, it takes that nudging sometimes from your family member to get you going and really paying attention. So Dr. Wells and Dr. Kane, how do we get the message to people that it's time to go and get something taken care of, because that's not normal, even though Big Mama had it or Big Daddy had it. It should have been seen by Big Mama or Big Daddy's doctor, but for whatever reason, access to care, access to health insurance, we never know. Racism, let's just toss it out there. Various things could have impacted. So help me out here so that we can help our audience out.
Well, let me just, touch that real quick, because, a lot of times we talk about access, but a lot of times what gets ignored is I don't want to know. You know,
Yeah.
everybody in my family has it. It might be terrible, but I don't want to know what it is. Or I've been in situations, particularly in oncology, where you're told what it is. You're flat out told you have a cancer. I don't have a cancer. You have a growth sticking off your breast. It smells terrible. But no, I don't have a problem. So sometimes people just don't want to know the answer, or it's the fear of knowing what it is, or they're going to cut off my foot because they cut off granny's foot, they cut off uncle foot, they cut off everybody in my family foot who had this problem, and nobody cutting off my foot. Whereas if you present early, we could treat the problem most likely, and you can reverse a potential complication that could lead to the amputation. Like Dr. Kane spoke about, lymphedema. A lot of times you have leg swelling. It could be secondary lymphedema. That is something that's treatable, not curable, but treatable, and it could decrease you from developing multiple blisters, which could then pop and become wound and could now take forever to close, because not only is your arterial circulation compromised because you might have diabetes that does affect the major and the small vessels. It affects the neuropathy, the neurons. So you may not know that you have a wound because your foot is numb. So you don't have the normal sensation. So by the time you turn your leg upside down and look at it with the mirror, now you have a giant wound at the bottom of your foot that you didn't even know you had. And now you have it, you're going to treat with your at-home treatments, which could be ignoring it, or it could be all the old-time stories that you come up with, which is all the old-time ways, leaving it open to air. So you leave it open to air, it dries out. You still have a wound, but now you have a dried out wound, which now you have to, do even more stuff to it. So sometimes it's just, I just don't want to know. It's not just, the lack of insurance, because a lot of people insurance is not getting the help, treatments, not just taking care of their foot. They're not seeing the podiatrist. They're not seeing the endocrinologist. The hemoglobin A1C, which Dr. Kane can probably speak more about that than me, which is the measure of how well they're managing their diabetes, is 14 instead of less than 6. So there's multiple things that you are not doing. You're eating that bag of chips, and you shouldn't be eating that bag of chips. And you need to take care of yourself first. You need to eat healthy, and you need to teach that to your children as well. So instead of, you might be running late, but don't run them through the McDonald's line. Nothing against McDonald's, but make a healthy meal for them at home. Or even if you have to do leftovers for the next day, you got to take care of yourself and pass it on to the next generation.
So,
Well,
how can you discuss the role of nutrition and lifestyle in
well,
wound?
before she do that, real quick, I want to comment on what she said. Denial. Yeah, a lot of people are in denial. They just don't believe, that's what's going to take them out, take them down. The other thing is, first thing a lot of people say, well, I put my hands in the care of the Lord, and not saying that I'm God or the Lord or anything else, but you never know what the Lord sent you to help, take care of it. And so denial plays a role with that. The other thing is, when they sit back and they see they're steady taking care of others, and as Carol said, you have to take care of yourself first. You cannot take care of anybody from the grave, but they put so much emphasis on trying to take care of others that at some point, because they didn't take care of themselves, they can't take care of others. And if they have loved ones whom can't do for themselves, they're actually doing them a disservice when they put those individuals before they put themselves, because once that individual, meaning the caregiver for others, is gone, then it leaves that person without any caregiver for themselves. So they have to think about it. And that's, Dr. Wells talks about it to him a lot of times, but that particularly should be the role of a primary care physician doing their job in terms of finding out who takes care of those patients, what those patients' responsibilities are at home, and so on and so on. So, and because it's not a show about primary care, I wanted to touch on that real quick. But they got their own responsibilities in terms of taking care of themselves. Dr. Wells or myself can do everything for them, but we just want to make sure they know that they should take care of themselves first. I always tell people like this: it's like being on an airplane. They tell you that this airplane is going down or we're losing oxygen in the cabin. What's the first thing they tell you to do? They tell you to put the oxygen mask on yourself before you put it on your 2-year-old or 10-year-old or whatever it might be. Okay, so go ahead, JT.
So I wanted to.
I'm sorry, I just have to say something real quick. I'm sorry, Ms. Turner. Something, Dr. Kane, and I hear that a lot as well, about, I'm putting it in the hands of the Lord. But what I tell patients is that the Bible says, we need to use wisdom. And by using wisdom, God is the one who created all these medicines. He's the one who created all the technology. So he might heal you by a simple miracle, or he may use the medicine to heal you through that process. I just saw a question that popped up real quick that says, what's a bed? How do you prevent a bed sore? Something like that. You basically need to change your positions very frequently. If you're able to move, you're sitting too long, your butt gets numb. That means you need to change position. If you're paralyzed, you don't realize that. So we just teach patients that they need to boost every 15 to 20 minutes, or you need to physically be turned every 1 to 2 hours. I'm sorry, Ms. Turner.
But that also raises the issue about Ms. Turner, since you mentioned that about a bed sore, sometimes the patient ain't able to do it, and they may need to get a family member may need to be in an attentive state, paying attention to rotate them, to move them over, or making sure that if they're in a nursing home or anywhere else, that the staff is doing, even in the hospital. You sometimes have to go in there and be very firm about them rotating and moving your aunt, uncle, mama, daddy, grandma, whatever. You have to go in there because they get busy. I'm not giving them an excuse. They may get busy, but by the same token, everybody else's problem is not the problem you and your aunt or uncle or whomever is facing. And so they have to have their care given as well. And so either the hospital or nursing home needs to hire more personnel or less lazy personnel, but that's a matter for further discussion.
So if you're just tuning in, we're talking with Dr. Carol Bowen Wells. We're talking about wound care, protecting limbs and preserving life. I shared earlier about my great-grandmother and seeing her lose her limbs. Dr. Wells, what myths or conceptions about wound care do you often encounter? And the reason I ask that question is because I know a lot of, growing up in my day, as they say, people would use home remedies when it came to wound care or taking care of oneself. So what are some myths or misconceptions or things that you want to dispel that people need not do and pay attention to what they really should be doing? I know that's a loaded question, but hopefully it made a little sense.
Yeah, I think what happens is that, there's certain things that your grandma and great grandmother did or does still do that does work. Nutrition is one of them. They live to be old age for a reason. Some of the things they do in wound care is a lot of, people, they do peroxide, which will damage their wound and the surrounding tissue. I've had elderly patients that have used turpentine. They have just left it open to air, as I mentioned before. And I think, as I said, just leaving it open to air just creates a dried out wound. It doesn't close the wound. They may think it's closed because it has a dry scab over it, but if you move the scab, the wound is still there. So what I would say is that if you have a wound or break in the skin that is not closing, you really need to, even if you see your primary care doctor, see somebody, because particularly if you're diabetic, And particularly if you have discolorations of your skin or somebody says you have poor circulation. Because if you don't address it and you have all these other chronic medical problems or swollen limb, that blood flow is not going to get to that wound in a timely fashion. And instead of now having a simple acute wound, which will be closing again less than 28 days, now you're stuck with a chronic wound, which could take years to close. So the sooner you can see somebody and at least let them tell you what's going on. Now, you may go home and go back to whatever you're going to do, like we put the lymphedema wraps, or the therapist put the lymphedema wraps on the patient, and they go home 24 to 48 hours later and they take them off. And then they wonder why the legs are not going down or the wound is not closing. So let's just, at least go see your primary care doctor like Dr. Kane and let them tell you, no, this is what you should do. If you need to see a lymphedema therapist, let's connect you to a therapist. If you need to have your circulation looked at, let's look at your circulation. But at the end of the day, if you get put on antibiotics because now it's infected, now you have to end up in the hospital. Now you have hospital issues to deal with. Now, if you're not able to walk and you're not getting turned, so now you end up with a bed sore, as Dr. Kane just mentioned. Now you end up with multiple other issues. Now you're weak. Now you're going home instead of walking out. Now you have a walker. Now you're going to trip and fall.
Wheelchair.
Now you're a wheelchair. So now you have a wheelchair. Now you're not getting up like you should. Now you have a bed sore. So it keeps going into the wrong direction. So again, just simply seeks medical attention. Don't use home remedies if they're not working after so many days. But I would say don't use them.
Yeah, what about those chronic wounds? And I don't know if people, if you ever treated someone for a wound, you got it taken care of, and then next year they come back with another wound.
Yes.
What's happening with those patients? Why is it what's going on?
Well, there are a couple of things. It might not be the exact same wound. It might be a different location, but because I was the wound doctor for the last one, they come back. But as I mentioned, if you've had a venous leg ulcer, there's a 70% chance that leg ulcer will come back within the next 1 to 3 years. And if it's a diabetic foot ulcer, there's a 65% chance that wound will come back in 3 to 5 years. I've taken care of a patient who had what looked like a fungus growth on his hip for 20-something years. And he had been in and out of the hospital systems. He said they would just, drain the site. The one thing you have to, or might not know, is if you've had a wound for a long period of time, it can actually transform into a cancer. Again, I'm a cancer surgeon by training. And so I'm a general surgeon, cancer surgeon. Now I do wound care. And so when I saw the patient, my first impression was this is a cancer until proven otherwise. It looked like a squamous cell cancer. And so when I took him to surgery, which is also another benefit of coming to our clinic, because I can take you to surgery. I don't have to call someone else to take you to surgery. I took him to surgery, and I did the surgery thinking that this is not just a simple wound, but this is actually a cancer. So my goal at that time was getting negative margins. So you have to understand what you're treating, understand how to treat. So sure enough, it came back as a squamous cell cancer, but thank God it also had negative margins. So he didn't have to go back and do additional surgery, did not need an additional treatment. I sent him off to see his a medical oncologist. And a month later, I did a skin graft and the site completely closed. And he's not had a recurrence as far as I know. I think he's left town or something. So, it's important that you understand what you're looking at. Now, the other thing I would mention real quick is that you also have other chronic disease processes like lupus that has skin manifestation. You have vasculitis. You have other chronic medical conditions. So you may come to see me and I'm going to say, look, you need to see your primary care physician because you need to rule out all these other things that could be going on. Pyoderma, you could have other collagen vascular diseases that,
Lupus.
yes, the lupus I mentioned, that just happens to have a skin manifestation. If you don't treat the chronic medical condition, you're going to be seeing me very frequently for wounds. And all I'm doing is I'm chasing your wounds, but we need to treat the medical condition. I have a patient who had a wound on his right ankle. He said he sprained his ankle, then he popped this wound. It didn't seem right, but I treated the wound. Next thing I know, he came back 6 months later on his follow-up. He had a wound on the back of his leg. And I said, something is not right. There's something else going on. And the skin is just one of the presentation or the result of this disease. And he has a rash all over. He's now going to a dermatologist, rheumatologist, GI doctor. Is this pyoderma? Is this Crohn's? The right leg wound. Now he has a left foot wound. So we need to figure out what's going on with this patient. So it's not just the wound doctor, it's everyone else needs to be involved in taking care of these patients. Because again, we want to treat the entire patient, not just the wound.
So are there any latest advancements in wound care technology and treatments that you've been using or that you see coming down the line that you can share with our audience?
Yeah, there's a number of different type of therapies out there, from the negative pressure wound therapy or the wound vac, depending on the company, from all the different dressings that are available, skin substitutes. You can do skin graft, you can do flaps. There's multiple other things that can be done that's non-invasive and not related to the operating room that can be done in the clinic that will allow the wound to granulate, epithelialize, and close at a much faster rate. However, it's important that you treat the chronic medical conditions, because if you don't treat and educate about the chronic underlying medical conditions, that wound will recur. And that patient, when the wound starts getting better, their depression lifts. A lot of patients who have chronic wound are very depressed. And you can see the change in their body language after they see the improvement. If they get a recur, it's really hard on those patients. So that is why we need to treat the entire patient and not just the wound in the patient.
So what should a person expect when they, during a visit to a wound care clinic? What does that look like?
I think what it should look like is that, like going to any primary care doctor, you do a comprehensive history and physical. You want to know everything that's wrong with that patient. The wound is just one thing, but do they have diabetes? Do they have high blood pressure? How do they eat? What did they eat? When's the last time you ate? What are you eating when you eat? Are you on dialysis? When do you go to dialysis? Are you going to your dialysis? So you want to know about compliance. Is the leg swollen? Do you have venous insufficiency? Have you developed secondary lymphedema? Do you have a history of cancer? Is this a cancer that's looking like a wound? So after you get the comprehensive medical history and you do your physical exam, then you can determine if they need diagnostic tests. Do they need CT? Do they need MRI? Do they need just a plain X-ray? Do they have osteo? Do they not have osteo? Do they need to see all these different specialists?
Wow.
Just the wound physician is just one of the multiple people. And I think just based on the cancer training that I have, you appreciate multiple disciplinary approach to wound care, because that's how you treat cancer. And cancer is like a wound, or wound is like a cancer. They have multiple similarities. They can get very worse or they can get very better, and you can die. And again, statistically, a lot of people with diabetic foot ulcer is an independent risk factor for early grave. It's an independent risk factor for amputation, and having the other complications as well make it very difficult.
Ty, I can comment on what Dr. Wells has been doing, because she goes in there and she takes an intense physical and history. And there have been times she's called me and made me aware of things that I was not aware of. I do a pretty decent job at, questioning patients, but I know how patients are as well. And I don't never get offended. Doesn't hurt my feelings when Dr. Wells call and tell me, did you know Miss So-and-so was doing so-and-so and so? It's like, hell no. If I did, I would have told her what not to do or what to do. And a lot of times, that's just personalities within people. They will divulge stuff to some people. Sometimes they divulge it to my MA, but never tell me because they may think that I'm a have some level of disapproval of what happened, which I might, but that shouldn't affect their therapy. And I don't necessarily express that to them. I don't penalize them for not knowing or not doing necessarily, but they may think I will, and so they tend not to tell me something. And when I have a person that's doing a backup in terms of interrogating those patients, for lack of a better description, interrogating those patients and finding out as to what is going on within their lives, and Dr. Wells calls me and make me aware of stuff, but that saves me a lot of headache, because then when the outcome of what we expect to happen does not happen, and we can find a reason why it did not, then that makes it easier for us to take care of that patient and make them better, to heal them of what's going on. Of course, we can't heal everybody, but by the same token, we get the best shot that we can. So like she says, it takes a very team approach to taking care of this. And when you have a team member like Dr. Bowen Wells, I can put it in her hands. And when she needs me to do anything in terms of antibiotics or anything else, she calls me and make me aware of it. I know how to jump on it because I can trust her judgment, because she really cares about what happened to the patient. That's what the patients tell me all the time. Dr. Kane, I'm afraid of her, but she's right. I did not do this. I was not doing this. I say, well, that means you lied to me about what you're doing. Say, well, yeah, okay. Yeah, I did lie, but I'm scared of her. Yeah, this big old guy. He's 6 foot, like 6'1", 6'2", and he's scared of he pays me absolutely no attention. But he was definitely afraid of her, and of course the girlfriend, because she told the girlfriend would rag on him right quick, or the wife, and so on and so on. But I had to put that in.
Well, Dr. Wells, it's been an hour already.
Oh, wow.
You've taught us a lot. Dealing with wounds, it's scary in my opinion. So I can only imagine how our clients feel when they come to you. But the good news, they are with you, and now it's time to jump into reality and deal with the situation. At the end of every podcast, we like to give our guests an opportunity to share their final thoughts. What are your final thoughts, Dr. Wells, regarding tonight's topic that you'd like to leave with our audience?
I think just focusing on the diabetes, because it's such rampant in this country, is that, if you have a wound on your foot, your leg, and you're being told that it's time to get an amputation, I would recommend getting a second opinion, because once you start doing amputations, you are changing your 5-year survival, and it's going to change your life in a negative way, not a positive way. And your 5-year survival is, as I say, it's worse than some cancers, including breast cancer. And so if you want to have a better chance of saving your limb, have them give us a call at Wells Surgical Services.
I was just about to say that, Dr. Wells. Shame on me. I didn't give, and do us a favor before you get off. Tell us a little bit about your background and what led you to get into this field, and then how do people reach out to you?
Okay, I've always wanted to be a cancer surgeon. I actually went to medical school, and my passion all throughout undergrad, I want to be a cancer surgeon. I want to cure cancer. And then I went to medical school. I was volunteering at all the cancer wards, as you can find. And then I went to residency, and then thank God I was matched to do oncology surgery, and I did my fellowship University of Miami. And then I came here, local to Jacksonville, as a cancer surgeon. And as a general surgeon, as a cancer surgeon, you were taking general surgery call. So everything that came through the door when you were on call, you had to see. However, back then, there weren't no clear discipline around here of wound care. So as a surgeon, as a cancer surgeon, you do know how to cut out horrible looking, awful wounds. And the best that we did at the time was to put a wound vac or negative pressure device on the wound to try to close it in. But I remember it just got overwhelming where you felt like you weren't helping a lot of the patients, particularly the venous leg ulcer patients, because once you discharge them from the surgery standpoint, where do you send them? Who's going to do compression? Who's going to do the other stuff that really make an impact on these patients' lives? And so I remember one day I went home, I was, very, very upset because I felt like I wanted to do more. So I remember I looked out the window of my bedroom and said, okay, God, if you show me how, I will do it. And next thing I know, I'm being referred most of the wound in the hospital, and my practice went from mostly general surgery oncology to 50-50 to now pretty much 100%, and it's been 100% for several years, wound care. So I don't do general surgery anymore. I don't do cancer surgeries anymore. I just do wound care because I think it's so important that you try to save people's limbs and you save their lives. And one story I have to say before I leave is I had a patient. It happened to be a patient of Dr. Kane, but it could have been anybody else's patient, where this patient had a wound in his foot. And he was tired of this wound on his foot, and he wasn't always compliant. However, he came in this one time, his wound had closed and it reopened. And it had gotten so bad because, again, he had neuropathy, so he didn't realize how bad the wound on his foot was. He came in, I saw him, and I said, you need to go to the hospital, you need surgery. And he sat there and he begged me for an amputation. And I said, you do not understand what you're asking me for. I said, no, you do not need an amputation. You need to do surgery and antibiotics, and let's close this wound. And he sat there and he cried, he begged me, and I looked at his wife. I said, no. And I called Dr. K and I said, you need to talk to this patient because I don't think he understands what he's asking. And by the way, I don't do amputation. And that's the reason why I don't do amputation. Because, you need to exhaust everything possible before you start cutting people's limbs off. And we maximize everything, and he still has his foot today.
Wow.
And this I'm saying, but in another person, you ask for an amputation, your foot's gone. Now, you can't put it back after it's gone. It's gone. Now, are you going to be able to do the high-level job that you were doing after you've amputated your limb? So again, be careful what you ask for, and please check your limbs. Check your foot every day if you're diabetic. See a podiatrist. Let them cut your toenails. Don't try it yourself and then cut your toe and then end up with a wound and multiple other problems. So I'm sorry, I probably went longer than I should.
Oh, no, you did. Now, lastly, how do they get in touch with you?
Pardon?
How do they get in touch with you?
You can give us a call at 904-503-8335. We treat you as family. Thank you.
Thank you so much, Dr. Bowen Wells. You really, really educated me more than I ever thought I needed to know about wound care. Again, Dr. Kane has been saying how important it is. And there are so many people who have a loved one, someone they know with diabetes. And so it's something that we don't take serious enough until it gets serious. Dr. Kane, what are your final thoughts?
All right, I'm not going to make it voluminous, but I got to say it. So before Dr. Bowen Wells came here, we had Dr. Jones, who was trying to do some of everything. I remember when Dr. Bowen Wells came here as a cancer surgeon, but she was going against the grain, not because of her skills. I think it's because of politics of medicine here in North Florida, and color had quite a bit to do with it. But she knows why, and she explained to us why she went on into wound surgery. And truth be told, even though I don't have a wound, that's the best thing that ever happened to me as far as wound surgery and wound care is concerned. Because now, before then, I had Ken Jones, who quickly noted that's not my area of expertise. And when Carol went into, for those that believe in Ken and have practiced, know what Ken is all about, he quickly went into send them to Dr. Bowen Wells because that's what she's doing, and she does an excellent job. He had no hesitations about her managing whomever I came across. What we have to remember is that wound care is a multifaceted disease. It can come from multiple things: diabetes, venous insufficiency, which means, what you think about when you say varicose veins. It can come from trauma. You just hit it and that's a problem. There's a whole lot of things that can cause it, including things like lupus or lupus-related diseases, including vasculitis. And we've been seeing vasculitis, which is inflammation of the lining of the blood vessels. We've been seeing quite a bit of that, especially with COVID, that old C word coming along. It might be microvascular, but that's even worse, because when it's microvascular, it affects, to the lower level of circulation. But of course, you affect the lower level of circulation, it can have probably a much greater impact in the long run of the bigger vascular circulation. Mm-hmm. The other thing is that she talked about cancers that are associated with it, and she's right on the money. We need to pay attention to other things that may be causing these wound care wound issues. And then, of course, you look at the psyche. Patients have had it for such a long period of time, get depressed. They are not looking into alternative means by which to take care of themselves. They've given up. And when they run up against, and Bowen Wells won't say it, but you guys know me, they want to run up against those white physicians who just are ready to go chop and cut your foot off, cut your hand off, if that's the case, that because they make as much money for a surgical procedure as they don't, because they're surgeons, and some of them don't really give a damn. I'm not saying all that are not necessarily black, but some of them just don't give a damn. If you say cut my foot off, they'll cut it off. That happened again. She made it correctly. It was a patient of mine. I'm going like, what the hell is wrong with you? Didn't you hear Dr. Bowen Wells say, we're not finna cut this foot off. We're going to make sure you walk and you won't be using a boot, a stump, or anything else. Wife came in and she beat the shit out of him. Excuse my language. She jumped all over him and told him, look, I don't want, Hopalong Cassidy coming around here necessarily. If we can do something about it, we need to do something about it. Where I have a problem, and this is her word, where I have a problem is you can do something about it and you don't. I don't have any sympathy for somebody who does not, that's her, who does not take advantage of an opportunity given to them, and she's a religious woman by the good Lord, blah, 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 blah. So my whole thing in terms of this evening is wound care and wounds are very important in our lives, whether it's you or your relative. And as Dr. Wells said, and y'all heard me say, I treat them as if my mama, brother, sister, son, daughter. I will give whatever I need to do to take care of them is what I would do. And I treat my patients the same way. And that's what I like about Carol. Her philosophy is she treats them like they family.
Thank you, Dr. Kane. I'm going to give my brief final thoughts before we show another video from Dr. Wells. As we wrap up this episode, I want to leave you with a few takeaways about wound care. Remember, wounds are more than just skin deep. Proper care is essential to prevent complications and ensure healing. Don't ignore early warning signs and seek professional help when needed. Stay proactive with prevention, whether it's through managing chronic conditions, maintaining good hygiene, or protecting vulnerable areas of your skin. With the right care and attention, you can significantly reduce the risk of serious outcomes, saving both limbs and lives. Tyrone, if you can go ahead and cue the video, and then we'll come back and wrap up tonight's show.
My experience has been great. Staff is friendly. I'm always laughing and joking with them. Booking is easy, get an appointment. Dr. Wells is always available 24 hours a day, even when it's holidays or whenever. She always tells me if I call her, she'll be there. If my wife has any questions about my wound, call her. She's always there to answer the questions. My foot is healed, no problems. I'm back in the shoe where I was walking around in soft boots, and it's healed. She saved my foot. She's always in contact with my primary care doctor. I would recommend Dr. Wells Surgical Center because she cares. Dr. Wells, you have any kind of wounds that you need healed, or somebody's telling you that they can't be healed, come to Dr. Wells. She can do it for you. She will heal your wound, and she's gonna take good care of you, make sure you're great. And she's got a winning personality, her and her staff. Great people all over.
That's awesome. I love the patient testimonials, Dr. Wells. Again, thank you so much for imparting all of your wisdom and knowledge. And I definitely can see your caring spirit. It's more than just a job for you. It's saving lives and saving limbs and saving lives. Thank you all for tuning in to Pause for the Truth. And don't forget to tune in next week. And please, please, please subscribe to our YouTube channel and share with others. pauseforthetruth.com, so folks can go on there if they missed tonight's episode. If you know anyone with diabetes or anyone who has that sore on their leg that doesn't seem to be healing, that swelling on their leg or whatever limb that doesn't seem to be healing, let them know that that's not normal and they shouldn't wait. They should get it checked out. Thank you for tuning in to Pause for the Truth, and we'll see you next time.
Now you see why you need to tune in every Tuesday at 6:30 p.m. Eastern Standard Time. It's been an absolute joy having you with us today on Pause for the Truth. Dr. Rogers Kane and Ms. Jocelyn Turner are so grateful for your time and support. We know you have a lot of choices, and we're thrilled you chose to spend your time with us. It means the world to us. A shout out to Tyrone Jackson of Call Tyrone IT Services for making everything run smoothly behind the scenes. Tyrone, you're truly a whiz. Remember, folks, we're here every Tuesday at 6:30 p.m. Eastern Standard Time with more insight, stories, and truths. So mark your calendars, set those reminders, and join us for another exciting episode. Thank you once again. And we can't wait to connect with you next week. Stay curious, stay engaged, and most importantly,